Good morning. My excitement to be here, I can't tell you enough. As you said, my great-grandfather was from Lithuania and came to the United States before World War I. So to have the opportunity to come here alone was tremendous, but to be able to talk to all of you is even better. So thank you. I currently work at Hospital for Special Surgery, which is an orthopedic hospital in New York City. It's the #1 orthopedic hospital ranked by U.S. News and World Report for the last 10 years, and it's been in the top 3 for the last 27 years. And so we have a long history in orthopedics, and I work now as part of the Sports Medicine Institute, and we take care of about 40 or so professional elite sports organizations. Dr. Pat mentioned the ACL study group, and one of the surgeons that is a member of that group with him is the chief of the Sports Medicine Institute now. And so we work very closely together with a lot of athletes who are already injured. But this map just shows where we're located on the Upper East Side of Manhattan. The hospital was originally founded in 1863, so more than 150 years ago, and it was then called the Hospital for the New York Society for the Relief of the Ruptured and Crippled, which is a really long name, and we don't use that anymore. But it was founded in someone's house. Dr. James Knight had a really large house, but he brought 25 or so young children with polio into his home and did surgery with them and did whatever they could to help improve the lives of these children. As the hospital evolved and went forward, Dr. John Marshall was the first physician that talked about sports medicine, bringing these scientific approaches to medical and the medical approaches to teams, to sports teams. And here he's with the New York Football Giants. He was their first team physician. And so Dr. Pat mentioned a lot of issues surrounding youth sports. And so we know what happens at the elite sports level. We see it all the time. You know, big names like Klay Thompson and Corey Coleman and Gudaitis, obviously, here in Lithuania. And it also, happens in tennis. Dr. Pat played the gruesome video of Bethany, who came to HSS as a patient after she tore her ACL at Wimbledon. So we know this is a big problem, but in order to fix it, you have to know your history. And Michael Crichton said, if you don't know history, you don't know anything. You're just a leaf that doesn't even know that it's part of a tree. And that's really true, and we take that very seriously. We have to know what the story has been told so far in order to tell the ending, or in order to create the ending. And so I'll go quickly through this, but we have to know what the injury factors are of ACL in order to help prevent or solve these from happening. We need to know a little bit about the epidemiology. We need to know how often and how much these are happening. And then we also need to know, obviously, the outcomes. What are the results of these injuries? And so there's lots of information in the literature, and I'll present just a bit. But the one thing to keep in mind here is that there's a huge gap between what's published in the literature and what happens in the real world. And that gap is, on average, about 17 years. And so we can look at the most recent data, which of course is super important, but knowing that it takes about 17 years to get that data into the hands of people in the real world settings is what we're all about and what we're trying to do, certainly speed that up. And so when we look at these risk factors, the first study here tells us that a narrow intercondylar notch, so the space between the bone where the ACL lives, if that notch is narrow, that's a risk factor. It's one that we can't do much about, but if we see that, we know that that's a risk factor. Same with the tibial slope, so the angle of the tibia. at the plateaus. That is also has been identified as a non-modifiable orthopedic risk factor. This systematic review said neuromuscular conditions, weakness, imbalances, lack of flexibility, those sorts of conditions that are modifiable were found to be a significant risk factor for injury. This study tells us that faulty mechanics, so the way that people move when they perform exercises or activities or when they play sports, so your movement quality is a significant risk factor. And if we look at ski racers, this study found that core strength, one component of neuromuscular control, but a critical one. If your core strength is limited, you're at risk of an ACL injury. So we see some combination of modifiable and non-modifiable risk factors, but that only tells us part of the history. We need to know how often and how much, and Dr. Pat showed a lot of great data about this. Some may be repetitive, but in looking at this group, we see that between the 6-year-old to 18-year-old age group, over the course of 20 years, we see a slow but steady increase in the number of ACL injuries. This study looked at a group across 21 years and found that the annual incidence rate, the frequency each year, increased significantly across those 21 years. So despite our best efforts, despite great surgeons and great physiotherapists, this number of injuries continues to climb. This study looked at high school athletes, secondary school athletes in the United States, and it was a systematic review and a meta-analysis, and there's a lot of data here. But basically, they found that the rate in female injuries was about 1.6 times greater than males, and that's a significant number. Both those rates in males and females increasing in sports like soccer, basketball, football, and lacrosse. And so all those running and cutting sports. Certainly not limited to the younger athletes. In college settings, we see that despite extensive research and development of prevention programs and a lot of resources with people to implement them, the rates in most college sports, with the exception of baseball, saw increases in ACL injuries. And again, looking at high school for athletes that played multiple sports, you asked about sports specialization. It found that despite the athletes that played multiple sports, their risk of injury for ACL continued to increase. Certainly not unique to the United States as well. This study from Australia found that the rates for injuries for athletes under the age of 15 were significantly increasing. I'm going to just go ahead and skip ahead then. And looking at the outcomes, and again, Dr. Pat did an excellent job of outlining what the main concerns are when you have an ACL injury. And so looking specifically at the United States, the financial impact is significant. If you don't have insurance coverage, which many people in the U.S. do not, you can expect to pay somewhere between $20,000 and $50,000 to have an ACL surgery. That doesn't include the cost of rehab. That doesn't include the cost of being in the hospital. And that doesn't include the cost of bracing or any medication that you would need afterwards. So that's a huge number. Specifically with rehab, when I used to see patients as a physio, at the end of my time treating patients, I had several young athletes come to rehab whose co-payment, their visit, that payment that they had to pay each visit was $100. And so if they came to physical therapy 3 times a week for 2 months, that's a lot of $100 bills that they had to put down, and that's on top of the money that their insurance paid for. So it's certainly a significant concern, the financial aspect of an ACL tear. Time is also something significant to consider, in that the most effective rehab research has shown to be at least 9 months. Dr. Pat's hero, Tim Hewitt, recommends maybe 2 years before return to play sometimes. So there's a lot of time involved here. The return to play rate, so not necessarily great numbers here, maybe somewhere between half and 90% of athletes who've had ACL surgery are able to get back to playing between 12 and 13 months after their surgery. So that's not great numbers. And then we look at how many people re-tear, somewhere between 9 and 25%. So if someone said you have a 25% chance of something happening to you, that's pretty significant. And when it's an ACL tear, knowing the surgery and the rehab you have to go through, that's not great. So the short-term impact, what happens immediately after in that first year or so, is devastating. But then we look a little further down the line into the future, and we see what happens at 10 years. And this review said that almost in some cases everyone, 100% of patients with ACL surgery have osteoarthritis in 10 years, some level. So that's significant. Everyone ends up with some degenerative changes. Using this data link, this group showed that the odds of needing a knee replacement before the age of 50 was 7 times greater in folks that had ACL surgery. And it was 15 times greater if they had a meniscus injury along with their ACL surgery. So I don't know about all of you, but I'm not quite to 50 yet, but I'm certainly not interested in a knee replacement. Not yet. This group looked at what happens after 20 years after surgery. And the median was 22 years after follow-up. And what they found was that this group was 4 times greater to have significant levels of osteoarthritis at that 20-year mark, almost 4 times as likely than those without an injury. And so if we look at the rates of return to play after someone who's had surgery on both sides, so bilateral ACL reconstructions, the numbers are just terrible. So one side bad enough, the numbers are really bad if you've had a reoccurrence or a second injury. So now that you have both, devastating numbers. The Moon group again looked at what happens 10 years afterwards, but they looked at quality of life. They didn't just look at osteoarthritis, and they found that certainly the osteoarthritis was there, but what they saw was physical activity rates decline dramatically. So when you look at an activity scale and you look at how much someone's moving, just physically moving, whether that's walking or jogging, after about the 6th year, it drops off dramatically. And so we have folks with arthritis who are not moving, and you can only imagine the downward spiral that they go through. And so this group did a tremendous job of connecting an ACL injury to mortality, because they said if you have arthritis and you don't move, you tend to gain weight. And when you gain weight, you have conditions like diabetes and high blood pressure and heart disease. And certainly those lead to premature mortality. So looking at short-term issues is one thing, but we see really bad things happening over the long term. And so I'll ask all of you a question. If we look at these injury prevention interventions, what is the most popular intervention? What is the gold standard? What should we be doing to prevent ACL injuries from happening? What's the thing that we should be doing? Dr. Pat talked about it. Dr. Pat will give the person who answers this correctly €20. No one's interested in 20 euro. Okay, I'll take it for myself. So neuromuscular training is the intervention that's most popular. So doing exercises that improve your strength or improve your balance or your proprioception. And so if we look at PubMed and we do a search each year from 1985 until this year, we can see how popular that became in the early 2000s and continuing on now. Neuromuscular training is the intervention. This is what the experts tell us is the most important factor that we can control for to reduce the number of ACL injuries. And so when we look at some studies, it's universally accepted that if you do neuromuscular training, the rate of injury goes down. This was a systematic review for youth sports, and they said there's significant evidence for the effectiveness of neuromuscular training. It's critical to influence the behaviors of young athletes by doing this sort of preventive strategy. A lot of you may know about FIFA and FIFA 11 Plus, and FIFA 11 Plus for Kids is a neuromuscular training program designed specifically for kids who play football or soccer. And this group found that the injury rates dropped by 46%. So huge decreases in the number of injuries when you do these neuromuscular training programs. However, it's one thing for that to happen in a controlled research setting, efficacy, and it's another thing for that to happen in the real world, out there where there's a soccer field, effectiveness. And so if we compare efficacy and effectiveness, we're now getting somewhere. Like I said, efficacy is the extent to which this intervention works in a research setting, controlled, ideal situations, everything designed to be structured perfectly. Effectiveness is the opposite. It's the extent to which that intervention works in real-world settings, where anything can happen, nothing is controlled, the situation is just left to what happens on a daily basis. So they're two very different things. Efficacy just asks the question, can it work? Can this intervention work? Effectiveness asks the question, does it actually work? In an efficacy study, the sample population is well defined. We do randomization and we select a sample that's defined, and it doesn't change over the course of the study. The protocol is fixed, it's very structured, and we measure compliance. That's the outcome that we get. We see how well did this very defined sample do with the very structured program that we put in place. Effectiveness trials, though, are very different. We take anybody. If you sign the form, you're in. The protocol can change. It's flexible. Because it's a real-world setting, what works in one study may not work in another. So we have to change that as we go along. And what we measure here is how much people use or consume the intervention, how much adoption and implementation is happening. So we're looking at two different things, but both obviously very important. And so here's an example. This study from Pollard looked at the results of an injury prevention program, and they looked at their knee mechanics of the studies when they did a drop jump. And they said, absolutely, this was a terrific study. They implemented this program for 12 weeks. But when you look deeper into the study and you look at the protocol that they used, they said that they used the PEP program from Santa Monica, California, some amazing researchers there, a neuromuscular training program. But each session was 20 minutes long, and it was overseen by an individual who was trained in the implementation of the program. So we don't know what that means. Who is this individual who was trained in the implementation of the program? That's the key. So we called them and we said, hey, who were these people? And they said, we picked our best physios, the best ones we could find. Well, I don't know how things work in most places in Lithuania, but I'm going to guess that youth sports teams don't have the best physios hanging around with them for 12 weeks, right? So this is a great efficacy study, perfect, controlled, ideal settings, and we get great results. But what it's not is an effectiveness study, because it's not a real-world situation. So what we need to do is look at real-world situations to get some sense of what's happening. And so in the United States, we have this profession called athletic training. These are sports medicine clinicians who work specifically with groups of athletes on sports teams. And in 2018, they put out a position statement about preventing ACL injuries, and it was terrific. They said that athletes and the folks that work with them, the clinicians, should develop these neuromuscular training programs. Absolutely. These are shown to be effective. And so then if we look at the competencies, the professional skills that an athletic trainer should have, they have a 100-page document that outlines all of the competencies, the skills that athletic trainers should be able to do when they practice. The second most important part of it is this prevention section. And so if we go to that prevention section, it tells us that absolutely these athletic trainers should be implementing these complex training programs. They should be supervising them. If we keep digging down further into this huge document, into this prevention section, it tells us that the trainers, not only should they be supervising them, they should be developing them. And we think, this is amazing. This is great. This is how we get it into the real world. But then when we look at the actual competency, the only one that they recommend for prevention is that they should implement disinfectant procedures. So they should wipe down the tables so people don't get infected. I don't think that's helping anybody not tear their ACL. So it's one thing to put it on paper that this should be happening, but the leading organization in our country for athletic trainers isn't teaching the athletic trainers how to do it. So that's where we come in. But I'll share a story before that. I'm going to tell this story at the risk of making the orthopedic surgeons in the room mad at me, but I'm going to do it anyway. This is a popular camping spot in the United States. This hill, it's very beautiful. You see all of this beautiful scenery. And so an orthopedic surgeon, a physio, and a teacher went on a camping trip. I'm making this up, so it's not real. But they went on a camping trip. They found this hill, and they said, this is the most perfect place to camp. We're going to camp right here. So they set up their tent. It was a beautiful night. They took this picture, and then after this picture, a storm came, and it rained and rained and rained. And it kept raining all night. And the next day, they woke up, and this very beautiful picture was a raging river. The water was rushing so fast. So they were packing up their gear and looking to go, and all of a sudden they heard someone shouting, "Help, help." And they saw a child in the water being rushed down the river. And so the orthopedic surgeon, being the person in charge and being the bossy one all the time, said, "Come on, let's go. We have to help that kid." So they all went charging into the river, and they rescued the child. And they got him onto the shore, and they heard someone else yelling for help. And they turned around, and there were 5 more kids in the water. What should we do? Well, of course, all 3 ran back into the water. And they grabbed as many of those kids as they could, and more kids kept coming down the river. And the surgeon said, "Well, I have to keep rescuing these kids." And the physio said, "Well, yeah, I do too, but I'm really getting tired. Maybe I should take the teacher and go up the river around that corner and see what the heck is happening. This isn't normal." So they left the surgeon to keep pulling the kids out of the river, and they went up around the corner. And they saw this bridge, and the storm had washed out part of the bridge. And the kids were trying to jump across the space, and some of them were making it and some weren't. So they were falling into the river and getting rushed down, and then the surgeon had to pull them out of the river. So the physio said, I have an idea. No one go across this bridge. We're going to set up a screening right over here, and I'm going to test whether you can jump across that distance. And if you can, I'm going to let you go. And if you can't jump that far, you're not allowed. We have to keep you here. So the physio and the teacher tested the children, and they said, you can't jump that far. You're not allowed to go by. And even some of those that could jump that far, when they got up there and they saw the rushing water, they got nervous and they didn't make it. And so now they're in the river, and now the surgeon has to pull them out. So the teacher said, I'm tired from pulling people out of the river. These screenings, we're getting there, but we're still getting kids in the river. I wonder if I should just teach them how to jump across the right way. And so that's what they did. And so they took this whole group of kids and they said, let's just teach you the right way to jump. And then, if you can make it across, you'll have a better chance of not landing in the river. And so what I'm really explaining here is a public health approach. We don't necessarily look at who's at the highest risk, although that's very important because they deserve some extra attention. But in a public health approach, everyone gets the intervention regardless of their level of risk. So in that group of children who was waiting to jump across the hole, everyone got instructed or educated on how to jump. They could have been the best jumper or the worst jumper or somewhere in the middle, but everyone was trained. And so that's population health. That's public health. Everyone receives the intervention. And so when you take this approach to an injury prevention program, there's 4 steps. So we have to define and monitor the problem. And that whole boring thing that I did at the beginning, going through all the research, that was defining and monitoring the program. We know that ACL injuries are a significant issue. That was step 1. In step 2, we identify the risk and the protective factors. And so that was the second part of the boring thing that I did at the beginning. Right? So we know what the risk factors are and we know what the protective factors are. And in the third step, we develop our interventions based on what we know. So what is the intervention here? What is the thing that will help stop this problem from happening? And in the final step, we make sure, as best we can, that as many people as possible are using this intervention. That completes that public health approach. And so I'll talk now a bit about these interventions. What did we do? What are we doing to create interventions that we can teach to people no matter what their risk? Well, there's 3 different types, and that's the story that I told. So these tertiary interventions, this third level, the goal there is to lessen the impact of the injury. Right? The children were already in the river. They were yelling for help. They needed someone to pull them out of the water. So they needed service. They needed support. And an example of that in sports medicine is surgery, rehab, sometimes medication. The injury's already happened, but we want to lessen the impact, and we certainly don't want it to happen again. So that's that tertiary level. Secondary level preventions are addressing the individuals at high risk. Dr. Pat and his team are amazing work that they do, and they're identifying the folks that are at highest risk. And I'll just tell you, I'll stop for a second. He said about 20% of the children that he tests demonstrate those high-risk maneuvers. I'm going to talk in a little bit about the stark difference, the very significant difference between children in the Netherlands and children in the United States. But the focus here is on screening and early detection. We want to know who's at most risk, who's got the biggest danger of having an injury And some examples in medicine are skin cancer screenings or self-exams. You want to detect something early. But now we get to the interesting part, and this primary prevention. The whole objective here is to stop something from happening in the first place. And so a lot of this is done with education, policies, access. And examples are health education, vaccinations, things that we do well upstream, teaching kids how to jump across the part of the bridge that was washed away. And if you ask me, the most important words on this slide are health education. And the author of this study is where we draw our inspiration from. So in 1996, a long time ago, this study was published, and it was a group of ski instructors, a group that had several ski resorts in the United States would hire instructors to teach people how to ski. Except the ski instructors were tearing their ACLs. At one point, they had 4 people left out of a field of 50 instructors. They had all had knee injuries. So what the heck good is that? We need to do something, they said. So what they did was taught the ski instructors how to move properly. They taught them how to fall. They taught them how to cut and turn so that they didn't tear their ACL, and they had tremendous success. But like I said, it was in 1996, and it is the only study that talks about using education to help reduce the risk of ACL injury, which is crazy. So fast forward to 2016. So I don't know, what's that, 20 years later. HSS, where I work, we started what we call a sports safety program. So we were very lucky to receive a grant to do this. And all we were told when I was hired is you need to stop kids from tearing their ACL. Great. How in the world do I do that? But I went back to this study over and over again, and I said, well, if they taught ski instructors how to stop tearing their ACL, maybe I can do what they did or something similar to teach children. And there's this great quote from Nelson Mandela that hangs on the wall in our office, and the folks that I work with, we look at this every day, and it's really inspirational. Education is the most powerful weapon which you can use to change the world. And certainly Nelson Mandela wasn't concerned about ACL injuries. He had other things that he was trying to change. But the concept is the same. And so what we do is educate. But we had to decide what we were educating about. Were we educating about injury prevention or something else? And so when we looked at injury prevention and looked at all of the science behind it, not in sports medicine, but everywhere, in industry, in factories, in places where injuries are common, what we found was a lot of common things. That injury prevention is about managing risk. And we use words like limit and reduce. And the focus is on the threat to the individual. And that's an external perspective. Things are happening on the outside that you have to defend against. And when we measure our outcomes, we measure the number of injuries that happen. And that's important, but it's a measure of failure. We're measuring how often did this intervention or this strategy fail. Or are we educating about how to preserve your health? So we looked at this option. And when we looked at health preservation, we found that health preservation is about managing the resources that you have. And we use words like promote and support. And the focus is on our assets. And in this case, in sports medicine, our asset is our athlete. And that's an internal perspective. We're looking in at this asset as opposed to all the threats that are coming from outside. And what we do here is we measure participation. And that's a measure of success. How often is that child showing up to play or compete or practice every day? And so if we look into the literature once more, we see that most oftentimes injury prevention programs have shown to be high levels of efficacy. They're efficacious, but they're not always effective. The real world application of an injury prevention program doesn't always carry over. But when we look at health preservation strategies, they do carry over. They work in controlled settings and they work in real world settings because their focus is different. And so we set about to create an effectiveness program, a program that would be guaranteed to show improvements for kids in real world settings. And so we use this integrative behavior model as our guide. And so what a traditional behavior model tells us is that if you have the right attitude, big thumbs. If you have the right attitude, if you have the correct norms about a behavior, if you understand that you have control, all of that influences your intention to do something. And if you intend to do something, that is the best predictor of whether you'll do it. And so if we look at coaches in the sports medicine setting, and if we say, do you intend to do this injury prevention program? They tell us, I do. I intend to do this. They're lying. They don't do it, right? If they did, those numbers wouldn't keep going up higher and higher. So we said there has to be something else. We can't just ask them if they intend to do this. There's other pieces to this. And so when we look at this integrated model, we say, well, of course they need some other things, right? They need some knowledge and skills. They need to know what to do. They need to understand how important it is to do what we're asking them to do. We need to make sure there's no barriers in their environment so that they can do this. And then they need to be able to do this a lot, over and over again, so that it becomes a habit. And so once we look at all of these things and then ask a coach, do you intend to change your behavior? They say, But this time they don't lie. They actually do it. And so that one piece of this whole model, this knowledge and skills about the behavior, is where we've focused a big percentage of our time and energy into this program that I'm going to describe. And so we have this musculoskeletal health preservation program. We don't call it that, it's too long. But in describing it, that's how we describe this program. And we've created curriculum for these four audiences: for coaches, for parents, for clinicians like a lot of you, and for the athletes themselves. And this banner up here says live. And so starting in 2016, we put these programs, these training, these education programs together, and we said, let's go find some people to train. And so out we went. And so in 2016, we didn't know what we were doing. We found 735 people to listen to us, which at that time for us, we were excited. We were excited that 5 people would listen to us. But the fact that we got 735 to listen to us was terrific. But in that span of the beginning, the first quarter of 2016 to the end of 2018, we did 219 total workshops, total trainings, and we almost got to 12,000 people, which was awesome. And you can see the numbers go up each year. And so here are just some pictures of my tremendous colleagues. I always get the honor of talking about what we do. These are the people that do what we do, and they deserve all the credit. So this is, like I said, some photographs of different things, different workshops that we do, all different sports, working with children, working with coaches, teaching them exactly what they should be doing. This was a workshop that we did that we live streamed to Texas, I think. And so you can see a lot of training, a lot of education happening here. Very, very focused on children, these photographs. But I'll give you some of our results. So when we talked to coaches and did training, we asked them a lot of information before the training started, and then we asked them again afterwards. But Starting in July of 2016, we worked with groups in our community, and we did 152 total live workshops that this data came from. And the data was from specifically just about 500 coaches. About 3/4 of them were male, and their mean age was 32. What we asked them beforehand was, have you ever coached an athlete who had an ACL injury? And they said, oh, did we ever? 45% of them had athletes who had already torn their ACL. So almost half of the coaches had someone who tore their ACL. Scary that 20% had 3 or more athletes who had ACL injuries. That's absurd. That's insane. They absolutely needed this training. And so we also asked them, how important is your knowledge of these principles? And 94% told us it was very important or absolutely essential that they be trained, that they know these things. And so we measured with questions on a survey their knowledge of these skills and activities, their confidence levels, and their perceptions, their attitudes. How do they feel about this? And as you can see, they had significant increases to the 0.001 level. So statistically significant increases across the board. And then we also measured how satisfied they were. Could they use this information in real world settings? And 99% of those 511 coaches told us they could apply these things that they've learned, that they were very satisfied with the workshop, and that they would recommend it to other coaches. So we were really happy about that. So then we did a study, and we said, well, what happens when coaches are trained? What happens when they go back to wherever they work and coach? Did we have any effect? Did we waste our time? And so we took one group in our study, and we just gave them the materials. We said, here you go. Read it when you like. Go ahead and use it if you think it's important. But that's all we did, was we just gave them our materials. That was our control group. And you can see that we observed them throughout the course of their sports season, and only about 22% of them led the warm-up that we were recommending, this neuromuscular training program. And in our workshop, we teach the coaches not only what exercises to do, but the cues and the feedback that they should be using when they use the intervention. And here, not even a third used the right cues. We gave it to them. They told us they were going to do it, but they lied. But the group where we did our workshops and the group that was trained in what to do, you can see almost 2/3 of them, a huge difference. They led the warm-up exactly the way we wanted them to after one 45-minute training session. The same number, almost 2/3 of them used the correct cues and the right feedback. So huge increases, a 200% increase in just doing the right work. 132% increase in using the right cues and the right feedback. And so this happened after one single 45-minute training. No follow-up, no future engagement. We were really happy with that. But what we saw was that the kids in the United States were struggling. The coaches we trained them, they were doing the right things, but boy, these kids were tough. Dr. Pat mentioned that 20% of the children that he screens in the Netherlands have some deficits when they jump and land. Well, that's a great number compared to the United States. Because here, I know this slide is busy, but here's where I want you to look. So for kids between 8 and 11 years of age, we ask them to do basic exercises like jogging, figure 8 run, a lunge, a squat, a broad jump, a plank. And kids from 8 to 11 years old, when we gave them the instructions on what to do, what exercise to do, a total of 21% of them could do the exercise the right way. And in the 12 to 15-year-old age group, it wasn't much better, 29%. Really poor ability, poor physical literacy contributed to this for sure. We were encouraged, though. We saw that if we took those children and instead of just giving them the instructions, we said, you know what? Here's some cues. Do this when you do that plank, or try to keep your knees apart when you jump and land. So we gave them those cues and that feedback. And you can see those numbers went up significantly. So it was almost half of this young group, the 8 to 11-year-olds, could now do the exercises correctly. And all we did was give them some cues. Very little training, very little education. And that number for the 12 to 15-year-old group was now almost 60%. So they just needed to be told the right way to do something. So we were excited about that. So we made a course for kids. And we said, let's take 30 or 45 minutes. We're going to teach them all about how to move their body when they do these programs. And so we started that in November of 2017. We worked with a bunch of partners in our community, and we did 121 workshops where we gathered some data. And so we got about 450 kids. About half of them were male, and their mean age was about 12 years old. And so we asked them these questions again before they came to us and after they finished their training. And we asked them things like, what's the function of your ACL? What does it do? What parts of your body should be aligned to have the right posture when you do these exercises? What should you do when you slow down from running quickly? What should you do when you jump and land? Or do you now understand how to do these things? And the dark blue is split up by ages, but that's what they knew before the workshop. And the light blue is what they knew afterwards. So you can see every single question had statistically significant improvements despite the question or the age group. And that's, again, down here, very high levels of significance. And so we asked them also about their self-management and their satisfaction. And it's hard to make a kid be happy with a motor learning workshop. It's not Fortnite, right? But they still told us that after the workshop, they really enjoyed the program. They would recommend it to their friends, so we were happy with that. Like I said, it's not Fortnite, so we were happy that anybody was able to tell us they enjoyed themselves. And so, like the group that was pulling kids out of the river, we're getting tired, right? There's a small team of us. There's a lot of children who play sports. In just the United States, there's 9 million high school athletes. We've got a few hundred or maybe a few thousand. We said we'll never reach them doing these workshops one after the other. So we said, let's make it digital. Let's put this online so that people can use it wherever they are. But our concern was, are we going to get the same outcomes? Is it going to be as effective having a video instead of us being there? So we tried to figure it out. And so this is what our platform looks like. We worked with some partners. These are some groups throughout the United States who helped push this content out to their members. And here's what we found. In just the first half of 2019, we reached more people than we did in the whole 3 years beforehand. So just this year, almost 13,000 people received education through the end of June. Our goal is 25,000, so we're well on our way. But like I said, we were very concerned about our outcomes. We wanted to make sure they were going to be the same. And so we ended up with about 8,000 coaches that we collected data from just since December. They come from all 50 states in the U.S. and 16 different countries, actually. 2 from Lithuania, believe it or not. And so, like I said, the knowledge increased 31% in the live workshops, and we almost fell off our seats. I told the epidemiologist who did the calculation, could you do that again? I'm not sure we're getting this right, because we saw 45% increase in knowledge in the online course. So we were worried about the number falling. It actually went up. So we were thrilled. And so we have a lot of coaches who are learning online, learning our program, learning what to do. And so a big part of our excitement that I share with Dr. Pat is being able to teach people, no matter where they are, what they can do to help keep children safe. I mentioned earlier, we're a small team. This is it. If you take me and put me in that group, this is the group that does the work and the training and the education that we do. So I give them all of the credit in the world. I just have the ability to come and talk about them. But this is Jonathan, AJ, and Jimmy. They have the energy of 100 people. They keep me young. They're significantly younger than I am. So they keep me going. But I give them all of the credit for the work that we do. And thank you very much for listening.
Okay, thank you very much for the presentation. We gave the Lithuanian name Juozas, Joseph, so Juozas. And do you have any questions concerning the topic and the prevention?
Can you tell the names of the coaches listen to your workshop? Lithuanian coaches?
Yeah.
I know their email address, but I would get in trouble if I shared it. But we don't collect names. Yeah.
Okay.
Of course, this is amazing. And then yesterday we talked about this, but now I was able to listen directly to you and Thomas. And okay, I do hope that will be possible in my country. Yeah, and can you explain a little bit more in detail? Yesterday I tried to understand, but I was not able to understand how it works with 3 people and you, 4 of you. Of course, you have increased team, but just idea how many people, the structure to set up something like you in Lithuania, where 2.5 million people only.
So when these numbers are, the result of a few years worth of work, but when we started, we went to one school in Haarlem, which is not far from where our office is, and we said, would you let us come and teach your coaches something? And they said, I guess. And we said, well, do you have issues with injuries with your athletes? And they said, oh, yes. I said, well, I think we can help you. Let us try and help you. And they said, okay, come. And so at first, it was just this guy, AJ, and I. We were the first 2 people that joined the program. So his role is to call people and email them and say, we have this program, we'd like to come and work with you. And then it was my job to do the work. So he got us the contact, and then I would go and do the training. And so a group of coaches, like all of you are sitting here, would come, and we would teach them what we wanted to teach them, and that's how we began. As we went along, more and more, we found more and more people were willing to listen to us. And so then we had to bring in Jimmy, because he's much more athletic, he's much younger, he's certainly better looking. And we said, Jimmy, I need help doing these trainings, so you're going to help with these. So AJ now had to do 2 jobs. He had to find work for me to do and for Jimmy to do. And AJ's really good at his job, so he found lots of schools and sports organizations for us to go and work with. And he was so good at his job that we needed to bring in Jonathan. Now, Jonathan is interesting because he doesn't work with us full-time. He just does this on a part-time basis when we needed some extra help. So he's a part of our team, but he's not a full-time employee. He just comes when we need some extra help. So that's where we started, and this is where we're at now. But AJ finds these schools and organizations that are interested in having this training, and we schedule time with them, and we go and do our training. The training that we do for coaches takes, we say, about 45 minutes or so, usually about an hour at the most. The training for children is about 30 minutes. Their attention span is about 30 minutes. Well, it's really about 5 minutes, but we stretch it out to 30. And so we try to get the training done with coaches, maybe right before their practice starts. With the athletes, we try to do it during their practice time or right before. And so that's how we go about doing it. The interesting thing now with our organization is that we're spread out. We have sites throughout the country. So we've been focusing largely in New York, where we are stationed, where we live. But we now have a facility in Florida, which is not close. And so we need to figure out how to do exactly what we did in New York in Florida. And so we're trying to figure that out now. So it sounds like there'll be someone else standing over here who helps us in Florida. But we're trying to figure that out. So maybe what we can do is put someone's picture here, and that'll be who's helping in Lithuania.
I do not want to be an orthopedic surgeon no more. I would like to stand there.
Well, considering what we pay, you might not be able to eat.
Okay, I have one question. You told us about the ideas which came from the hospital, yes? And have you any good example in the States which comes from public health sector? Is something done in public health area?
No, it should be, but it's not. And so there is one section, there's an organization called the American Public Health Association. It's massive, 80,000 members. There's one committee that looks at sport and recreational injuries. And there's 6 people, I think, on the committee, and I'm one of them. So it's a very small group looking at this sort of stuff from a public health perspective. We have a way to go to make it be much more recognizable, and certainly something that the public is aware of. But it's from the public health side of things. There are other issues that in the United States that kind of are seen to be much more important.
Okay, thank you very much. Okay, one more question.
Strange question, but okay. You mentioned about the notch and the tibial slope. As an orthopedic surgeon, I dealing with this every day. Is it possible to manage this, and how it's possible?
I can't manage it, right? The notch width and the slope of the tibia, you can manage, right? But it takes a lot. So I'll share with you. When I was young, I tore both of my ACLs, and I never had surgery to correct them. So I was maybe 17 or 18 years old and never had surgery until I was 40-something. But I had a tibial osteotomy because my varus angle was about 18 degrees. Yeah, so I had, and obviously still have severe arthritis, but they needed to do the osteotomy to pull the limb back into alignment. But my tibial slope was pretty severe when they did that surgery. And then they also reconstructed the ACL for me at age 40-something. Who cares now at this point? Yeah, so you can't do much about that from an orthopedic perspective, but you can certainly reduce the risk if you jump and land the right way, if you know how to run and cut. No one ever taught me, obviously. So that's what we're doing. We can't do anything about those osteo factors, but we certainly can do something about how the kids move, whether they have a severe slope or not. Thank you very much.
And the last question.
Oh, sure.
Does Kristaps Porzingis had the ACL prevention program when he was playing at Knicks?
No, funny story though. He tore his ACL when he was playing for the Knicks, and the Knicks are one of the teams that our physicians take care of. And we will always look at, those high-profile athletes with my team, and we'll say, oh boy, we think it's just a matter of time. And he was one of them. We would watch the video of him all the time. We played it maybe about a month before. He went up for a rebound, and you asked the question about Valgas in loading and landing. Well, he loads like this, and he lands like this. And it doesn't help that his legs are this long. He's got really long legs. But we said, he needs to stop doing that. And then about a month later, we saw the headline that he had torn his ACL. So it's certainly unfortunate, but now I know that he's being taught the right way to jump and land. So hopefully he doesn't have a second ACL injury.
Okay, thanks a lot.
Thank you.
Okay, thanks, Joseph, for the presentation. It was really nice that you came here to Lithuania.